Alright, Pharmacist Interventions Part 33. Don't mind the pumpkin seeds, my girlfriend and I were carving pumpkins last night, they're drying out. Anyway, I had a doctor send in a prescription for desvenlafaxine 100 milligrams, and it was written take 1.5 tablets daily. It's not recommended to cut this tablet, it's an extended release formulation, but I'm going to talk about why. My hair a little crazy right now, not gonna lie. So I'm going to show you some slides from my lecture in dosage forms. It was a 3-part series of modified release systems. So a modified release system is basically any release system that is not immediate release. So it can be extended release or delayed release. I honestly think that delayed release drugs are a lot cooler than extended release drugs. An example of a delayed release drug is like mesalamine, so like Lialda or Pentasa. We use this for ulcerative colitis and Crohn's disease or IBD. You want the drug releasing in the colon, like not super far down the digestive tract. You don't want it releasing in the stomach. It needs to get to the site of action. So what's important to know is that the pH in the stomach is pretty low. It's pretty acidic, but as you go down the digestive tract, it increases, gets more basic. So in order to deliver drugs to the colon, we have a pH dependent release system, which is really cool. So mesalamine actually has like a little coating or a little polymer film that doesn't dissolve until the pH increases. Since it's on my mind, another cool thing is Cymbalta or duloxetine is a delayed release capsule. You can open it up and put like the pellets on like applesauce, but if you open it up and put it in on like pudding, something that has a higher pH, it can cause premature release of it. So duloxetine is formulated specifically as a delayed release because it's acid labile. So it's coated to protect it from degradation in the stomach. I could talk about drugs for hours, but drugs can be enteric coated also to protect you. So aspirin causes direct insult to the stomach lining and can increase the risk for ulcers and stomach bleeds. The idea with enteric coated aspirin was that like by enteric coating it, you can protect the stomach lining, but there are some studies that show no difference between the enteric coated and the OG aspirin. But also for patients having a heart attack, we usually recommend to take aspirin. So you can also chew and swallow the enteric coated so you have a faster release. Aspirin and NSAIDs also have indirect mechanisms in which it causes an increased risk of ulcers and bleeds too, I'll mention. These are a couple cool charts that show the GI physiological differences between a fasted and a fed state, aka empty stomach and with food. There are a handful of reasons we recommend some drugs to be taken with food and some drugs to be taken on an empty stomach. It has to do with either mitigating side effects or increasing bioavailability. There are a lot of things pharmacists have to consider when it comes to bioavailability in drugs for specific patients. Bioavailability is basically like you swallow a drug or put on a patch, how much of that drug actually gets into the bloodstream. There are a lot of different types of modified release systems. This is the inactive ingredient list for desvenlafaxine. Drugs have a lot of ingredients in them like bulking agents, lubricants, coloring agents. Here we see hypromellose or hydroxypropyl methylcellulose, HPMC. HPMC is one of the polymers that we use in a hydrophilic matrix system. It's a dissolution-controlled modified release system. These contain a water-soluble polymer that swells with the presence of water. This creates a gel layer that controls the release of a drug. It's the most widely used system for sustained drug delivery. There are a lot of pros to oral modified release systems like maintaining therapeutic plasma or drug levels, reducing medication side effects, improved patient compliance and adherence, and then as I mentioned earlier, targeting specific areas like with mesalamine and Crohn's and ulcerative colitis. There are also some limitations or cons to oral modified release systems. One example is dose dumping. This is the undesirable phenomenon where you have a drug released too quickly or in an uncontrolled manner. For example, some ERs you can't crush because you crush them, boom, it's gonna slam you. All the drugs are gonna hit at once. This can cause excessive drug concentration, side effects, and toxicities. So manufacturers gotta be careful when they're formulating an extended release formulation, like for example an opioid. They gotta be careful, like can this pose a risk for dose dumping? I'll also mention some extended release drugs can be split, like metoprolol succinate and Cinemet CR. If the manufacturer says that a drug shouldn't be cut or crushed, I would generally recommend against it. If you're a practitioner and you want to prescribe an extended release drug and have the patient either split it or crush it, talk to a pharmacist first. You can tell that these can be cut because they're scored. Scored means it has this little divot, so that's where you can cut it. Another con is therapeutic efficacy can be compromised if you miss a dose or two. I'll briefly mention that with brand to generic interchanges, we use the Orange Book. Basically, the FDA's Orange Book tells you if a generic drug is bioequivalent to the brand, meaning that it has the same desired outcome for the patient, so efficacy. So the generics have different ratings. These are some more examples. Modified release drugs can also be more expensive. Here's an example of the cost of the osmotic release metformin. It's literally over $1,000 at some pharmacy chains. I always see providers prescribing this by accident and not knowing that it's like over $1,000 and insurance won't cover it sometimes, so I have to call and have them switch it to a different ER brand. In this situation, I called the provider and let them know that they shouldn't cut Prestique. I saw what they were trying to do. They were going from 100 and they wanted to increase them to 150 milligrams, so they were like, yeah, just take 1.5 of them. I could tell the physician was irritated when I called them as like a community pharmacist to bring up the issue. But as soon as I told them like what the issue was, they're like, oh my god, thank you, like inactivate that, I'm gonna send in a new script. Is cutting Prestique super dangerous for the patient? Probably not, but you're gonna have the drug outside of therapeutic ranges for the patient. With immediate release doses, we see this like A sawtooth kinetic profile. I like this little chart down here because within Vega ER you could see like it's pretty steady dosing. I like this chart too. Here we have immediate release with the red line and it goes and then it hits underneath therapeutic range at about like 6 hours. This is just an example. With sustained release with this little blue one, boom, we have it in therapeutic range for much longer. I will mention that most drugs follow something called first order kinetics, meaning that the rate of elimination is directly proportional to drug concentration. These are some of my notes that I condensed from some of the lectures in school, but kinetics can be pretty complex with modified release systems.